Oh, thank you. Hi, so I'm Anna. I'm child psychiatrist in Cambridge, also assistant professor of child psychiatry and medical informatics. And a lot of the work that of the project that I'm running is really trying to think about how we can move towards an early identification and prevention system for children's mental health. So trying to address some of the problems we've got around getting access to care for CAMS. And in order to do that, we're designing digitally supported pathways and thinking about how we can use data that's routinely collected to support those pathways. So I'm going to present today a little bit about how. And sorry, I should say, just to provide context, as we're, really, have been so excited by the data that's been collected in SAIL and how that can be and has been used to really support our understanding of mental health, but also to support health service improvement in Wales. And so we're trying to do that in a small way in Cambridge. So we've been trying to link together health education, social care data, which is a programme that's ongoing. But while we've been doing that over the last 3 or 4 years, we've been using the SAIL data to really try and understand how we can use this the value of linked data and integrated data to be used to build tools and to develop our understanding of children's mental health. So today I'm going to be talking a little bit about the work that we've been doing and the team's been doing around really trying to understand how we might use linked data to measure various variables and mental health outcomes and how we can use that to build then predictive models in the future. And talk a little bit about just some of the needs and some of the issues that we're trying to address. So I'll share my screen now. There we go. Is that working for everyone? I'm going to plough on. I can't see anyone, so shout if there's a problem at any point, and that's not a problem at all. So we all know there's a crisis in children's mental health. So the prevalence has been increasing, for years now, and now we're at the point where around 20% of young people have got a diagnosable mental health problem that would benefit from an intervention. And we all know that that CAMS is struggling to meet that need. So if we try and understand, so we're going to initially use data to try and understand some of those problems. And we know that if we look at who it is who has contact with children day to day, then lots of people have contact who know children really well, so teachers, GPs, educationists, social care, but only a small proportion of the people who have contact with children day to day are in a position to be able to identify a mental health problem, diagnose it and get a child into treatment, so about 25%. And so the system we have currently is that CAMS as a specialist system does all of the assessment for all children, which means that these non-experts, apart from the mental health professionals, are identifying possible need and then referring into CAMS in order to get assessment. And that means, there's a bit of a mismatch in terms of the people who are needing help who get referred to CAMS and those who are referred. So lots of people get referred who don't need help, and lots of people who need help don't get referred. So we have this real unwarranted variation in referrals. And if we look at the capacity to manage all of those referrals, I think it becomes really clear that we don't have it in CAMS. So if we just look at the data between April 2019 and March 22, we can see that the referral rate for CAMS has more than doubled. So 60,000 over 128. And that means that now we're in the sad position about 70% of children who've got a mental health problem are not accessing care within a year. So the children who receive help are, again, not necessarily all the children who need help. There's this mismatch. So some of the people who are referred do actually receive help, even though actually CAMS might not be the best way to manage their problem. But we also have these children who need help, but who still aren't getting it. So one of the things we're trying to do is to think about how can we use data to solve these problems? Where are the children that need help but don't get referred or don't receive help? And so we've done a piece of work across our system to try and identify where those potential cohorts are, and one of the first ones is social care. So we know that from the literature and the data on social care, mental health need in kids with social care contact is really poor. But we know that actually the literature says probably almost all of the children, I don't know why these things do this, almost all of the children who have got social care contact need to have got some kind of mental health need. We know that some of them are referred in, a lot of them are rejected by CAMHS in the UK anywhere, and many of them are missed. So there's a real mismatch here. If we look at community peds or A&E, so acute systems, there's two cohorts here. So around, if we look at all of the children in an acute paediatric service, we know that around 30 to 40% of children who are being managed often seen lots of times with lots of investigations to try and figure out what's going on in acute paediatric or in a community paediatric or acute paediatric setting actually are there because of an undiagnosed mental health problem. And if we're able to identify mental health problems in this cohort, then a huge proportion wouldn't need to be managed there. And then the second cohort is actually children in those systems have got unrecognised mental health needs, which is leading their physical health problem to be slower to treat, harder to treat, and more complicated to treat. So we've got two cohorts there who have needs, and many of which don't get referred or get managed by CAMHS and have mental health contact input. So what we really need to do, just for these two cohorts, we really need to try and understand how we can identify the children who need help but being missed, and how we can reduce the number of children who are getting help who perhaps don't need it in a specialist service. And one thing that is really clear from this is there's no one single data source that can help us do this. So it's not that if we have all the GP data or just the mental health data or just the clinical data, acute data, we'd be able to solve this problem. We absolutely need integrated, linked, multi-agency data in order to be able to solve and understand these problems. So with our programme, what we're trying to do with this, well, first of all, we're trying to really provide some clarity to this complicated problem here and get to a position where actually the children who need help are the people who are receiving help. There's a much lower mismatch between those who are referred to CAMHS and those who actually need CAMHS help. So we're not really clogging up our assessment systems. The children with social care needs and who acute systems who have mental health needs are getting it. And really, we want to be able to shift thinking so that we've got the ability to distinguish between those who need specialist CAMHS service and those who can be perfectly well treated through a low intensity community provision and who don't need to be managed within a tertiary specialist CAMHS service. And the hope is here that we'll be able to, as I say, get the children who need help to have help when they need it, but also we can reduce the capacity and difficulties that we are currently seeing in CAMHS. So how are we doing? So, and the first thing to say is that if we are able to do that, or our view is that predictive science has got a huge amount to offer in this. And we've done quite a lot of work thinking about actually if we were to be doing predictive science, trying to identify these children early, what would be the data that we'd need? And it's really clear that we, from what I've described, but also the literature, that multi-domain data absolutely needs to be is required for this. So we need to have information on clinical information about how the outcomes and children who have mental health problems and who don't. But we also need to have detailed information about the environment, and then it's possible that in the future we might want to have genomic data as well. And if we're in a position where we can integrate all of these data types, we're going to be in a really strong position to be able to identify those who have need in the community. And the second point is that this data really does need to be representative, and that's why having whole population data is absolutely crucial. So if we go and collect very detailed information, which might be very much more accurate than routinely collected data, but it only involves those who choose to participate in research, yes, the data quality will be good, but we will essentially only be doing research on white, well-off people, because if we look at all of the research pretty much that's done on these cohorts, we can see that the people who participate tend to be 80 to 90% white, and they tend to be really well off. And that means that the research we're doing is not representative and it is not able to help those from a broad range of backgrounds. And we know that from a data science perspective is if we do the science on data sets that aren't inclusive, then actually the outcomes and the models that we're building are not generalizable to those from underserved groups. So it's absolutely imperative that we have whole population data to address this. And then the final point is that it is very easy actually to build very accurate predictive models, even for mental health, with area under the receiver operator curve figures of around 0.995, certainly in the dementias, where we have, you know, very, very detailed research data, including PET scans, EEGs, multiple psychological interviews, which repeatedly carried out. But it doesn't matter. Even if I build a model that is 0.99 accuracy, that can identify who's going to have a mental health problem with those data, it will never ever be used in the real world, because we can't currently manage to do the very inadequate assessment, the process that we have now. So if I build a tool that says you need to do a couple of MRIs, do an EEG, and have about 3 hours of interview testing in order to predict a mental health problem, it will go nowhere. So our view is that if we're going to be building tools which are implementable and can be useful in a clinical system, it needs to be using real world data, so data that is routinely collected within our systems. And it might well be that there's one or two helpful indicators, for example, genomics, that in the future might contribute to those models, but it needs to be on a basis of use of real world data. So I'm going to be presenting two projects. So one which is a piece of work which is very much led by our fantastic PhD student, Catherine Parkin, and there's other people who've been contributing to that, and she's been doing it as part of her PhD with support from others. And the first thing we need to do is to really understand what data we needed to use and what was available and what could we measure to solve some of these problems. So the first stage of this process was to say, actually, what is our frameworks and what data do we need to be able to build these predictive models? And so Catherine led on a piece of work to create using a Delphi study to create a framework of risk factors that would be really help us to predict mental health outcomes. And it was, I'm not going to go into detail, but it was a long process which involved a review of reviews, followed by a 3-stage Delphi with about 50 participants, all of whom had a broad range of experience in child mental health, from trauma, education, clinical, average experience about 20 years experience of working in the field, including academics. And we developed a framework which had these domains in it. So it said that social, environmental, behavioural, physical health data, education, employment, psychological and mental health and ill health, patterns of service use, and biomarkers are all probably the key domains. And then a big part of that programme was to say, actually, what are the factors that are particularly relevant for predictive science to those from underserved groups? And this came through from the Delphi. And so there's this eighth domain, which draws and collates the variables from these different domains, which are particularly relevant and need to be thought about when we're building models or doing or epidemiology or studies that at a population level, which make sure that we're not missing key cohorts for those from underserved groups. So this is just an example of some of the factors that came out of that. So you can see here there's some of the domains, and these factors were divided into 3 categories within each domain. So those that work at an individual level, at a family level, and those that work at a society level. And that's helpful because it helps us just give an indication of where we might get some of this data from as well. Things not working now. There we go. So the first step was to collate a data set. So we looked at these variables, and Catherine spent ages looking at all the different data sets that were available in CERN and trying to determine which were the data sets that would be most useful. And to her credit, we found 18. So I don't think this has been done. I'm not sure if this has been, Sale tell us if this has been done before, but we actually decided to link 18 sales data banks so that we could have a full range of multi-agency data. And that included demographics, health, social care, education. And the information was collected between 2013 and 2020, and we included people between 0 and 17 to construct this data set. And these are the different data sets that we identified within SAIL and we linked. So we did this with the support of the SAIL team as well. So they helped us do the linking. It was quite a big undertaking, took lots of time. So thank you for your help. And if we look at the temporal coverage of those data sets, we can see here. So here, sorry for the acronyms. I know it's not very helpful because it doesn't really mean anything. But essentially, there's demographic, education, social care, health, community, and acute healthcare data sets. And you can see here, we just wanted to see what the temporal coverage was. Because if we were going to be doing epidemiology work on the linked data, we needed to find a time period where we had most of the data about most of people. And certainly if we were going to use that for predictive modelling. So we decided that we would create a cohort that spanned from about 2009 to about 2018, because it had pretty much all the data we needed in it. There was a good kind of overlap for all the different domains and data sets that we're interested in looking at. And so here you can see an overview of the cohort. So this shows us what the data set we were measuring was, the number of people within that data set, and then the proportion of the cohort that they represented in. So you can see that obviously for the demographic data, that represented 100% of the people, and we created a cohort of just over 1 million children and young people. And of that, you can see, interestingly, that we had about 70% of those children were in the education data set. In the social care data sets, small proportions are in the social care data sets, as you'd expect. Nearly 100% of the children were in the GP data set. About 60% were in some kind of acute data set. And you can see here for the community providers, there was a range, but a large number of children were in the data in those data sets too. And just at a high level, the cohort demographics, this is the age group here, so between 0 and 3, 3 and 6 years, 6 and 9, 9 and 12. You can just see portions of children in each of the cohorts, and you can see it as about 50-50, very close to being 50-50 split from a gender perspective. So the next thing that Catherine did was to figure out, so when we were looking at the variables that we wanted to measure and the variables that were available across those 18 data sets, it became really clear that actually, completely understandably, because the way that we developed the variables that we wanted to measure was through systematic review and the Delphi. And so from the systematic review perspective, or it was a scoping, it was a rapid review, sorry. We looked at umbrella reviews, which looked at studies which had an association between a risk factor and a poor mental health outcome, and we extracted variables that had a significant association within a study that was judged to be of good quality or better. So that was our starter for 10, and we put those in the domains. And then we said to all the experts, okay, from your experience of working with children, because we know that the research and literature is great, but actually it's only those variables are only going to be in the literature if they've ever been studied, and we know that there's lots of things that might impact on poor mental outcomes that aren't studied. So we said to the experts, from your personal experience, what other things do you see in your practice that you think would lead you to expect there to be a poor mental outcome? And then we put those factors through this 3-stage Delphi, so getting other people to say, oh, actually, I agree, or I don't agree with that. We had 287 variables that we wanted to be able to measure in the data bank, and it became clear that this wish list wasn't available in routinely collected data. So the first question was to say, actually, what can we measure and where do we get that in data? And Catherine found that actually about just under 20% of those variables were directly measurable. And by that we mean is that, we said we wanted to know about bullying, and bullying was directly measurable in one of the data sets. And then she mapped that across the different data sets to give us a sense of where the variables of interest were lying. And you can see here, again, it provides more evidence of the fact that if we're going to be taking this predictive approach, we absolutely do need multi-agency data to be able to do the measurement of these adverse childhood experiences and other risk factors, as well as to be able to put them into predictive models. She then looked at and said at all the variables of interest and said, actually, and I haven't got a slide on this, but we can add it in the future, is are there any here that we could probably derive quite easily from the data, from the data that's there? And by that we mean, so for example, a BMI is calculated by height and weight are the two variables you need to calculate that. So it might well be that BMI wasn't a variable, but if height and weight are there, then actually we can extract that fairly easily out of the data set and create it. So there was a second category which were kind of like easily derivable. And then there was a third category which were like a bit of a challenge. And those are the variables which we think in the future, when we have access to free text or and we're thinking about how we might use large language models, that we can generate using NLP or large language models. And so actually we felt that there was probably about 60-40 split for the remaining variables in terms of those who were able to be reasonably easily collected and those who would need to do these more complicated methods of generating the variable. And this just illustrates, again, another way of looking at whether multi-agency data is critical to this. And you can see here that for the variables in each of the domain, we looked at whether they're available in the demographic data sets, the education, the social care, GP, community and goods. So interesting, I thought most of the stuff we'd find in GP, but it actually was not the case. And a lot of the stuff we wanted that we could measure was available in the social care and community healthcare data sets. So it just gave us a sense of actually where the real data sets of interest for this work were. So then we did a piece of work. This was led by Ryan, who's one of our MPhil students, supported by lots of data scientists and clever mathematicians in the Department of Maths. And we thought, actually, let's see if we can use just the variables we've got access to and say, is there any way, is it possible to predict mental health outcomes? And we were interested in thinking about one of those cohorts, which was the social care cohort. So I just want to look back at this and say, actually, if we're starting to think about how we can use data for prediction across the pathway, there's various different points. So one of them was thinking about, can we stratify the population? So can we identify those who are suffering particular risk factors or have got particular mental health outcomes? Can we put those variables into early identification systems so that we can spot who might have a problem, who doesn't? Can we do signposting? Can we identify those at risk of harm? Can we identify relapse? So we're really at the beginning of this pathway here. So we've done a little bit thinking about population stratification. We're doing more to think about how we can measure and understand that. But then the second point, we're at the second stage now saying, actually, is there a way that we can identify mental health problems using this data? So we decided to build a tool, first of all, for social care children. So children with contact with social services, to say, actually, can we provide a tool that social workers might be able to use to give them some confidence in whether there's a diagnosable mental health problem here that they should be referring into CAMHS or not. And so the data, we used all of the data sources, and we created a cohort that were of children who were 10 years or older. There was linked data, and we needed to know if they had what their mental health outcome was. And we had a cohort of 26,000 or nearly 27,000 interest in the cohort, and we split it into training, validation, and test sets. So we had mental health outcomes, which we included for this prototype were the presence or the absence of one, so there was no severity scores, and we were interested in depression, and we grouped these to say, is there a mental health problem, rather than can we define depression or anxiety, because we just want to say, is there a problem, do they need proper assessment or not by a specialist service? So we included these disorders, and at this point, for this first part, we decided to exclude developmental learning, mainly because of their age group. And substance misuse, because we wondered if that was a different cohort. So at the moment we're distinguishing disorders that would be managed within a CAM service. And so we had 101 risk factors, we had ICD-10 codes, and there was and there's an issue about there. So we wanted to look at different types of models, and we wanted to test. So one of the other big questions in the literature moment is actually, is there any value in machine learning over other AI, over standard traditional regression methods? So we wanted to have a baseline of looking at what does logistical regression offer? And then are there any other types of learning models that we might use that could build a more accurate model? So this is a research question, which, you know, kind of interested. We looked at how we might weight the classes, and we looked at, we didn't do feature selection, and we did a range of tuning steps in our validation set. So the data set we used here, you can see, is just an overview of the different proportions of children we had. So we had, actually it was 10 to 21 in this cohort, male and female, slightly more women or people born as female than male, and not particularly diverse, but that's not a reflection, we hope, of data poverty. It's just a reflection of the cohort that were living in that area. So you can see here that actually we were surprised that we got pretty good data. So even though we only had a small number, you know, a really small proportion of the variables that we ideally would have liked, according to the Delphi, the ability to have access to this broad range of variables across multi-agency data meant that even for our prototype, our first stab, we had a pretty good accuracy. So, and interestingly, logistic regression was most often in these studies, logistic regression is often as useful as other models. And you know, arguably there's not much in it here, but interestingly, our most accurate models are support vector machine. However, if we look at it from an explainability perspective, it's kind of always helpful and interesting to think about actually what were some of the variables that were contributing most to this model. And so here we've got just results for the regression model, so we can see that. And there were 40 parameters, as I say, included, and you can see here just a figure that shows you the odds ratio and the particular contribution for each of the variables to the model. And you can see the things which are some of the most important variables that did predict mental health illness within the social care cohort. And so you'll notice here also that there's one of the things we found was that quite a lot of the variables which were quite predictive actually were variables where it was like missing data. So, for example, we don't know if there was a 5-minute Apgar score was predictive, and we don't know if health surveillance checks had been done and that was predictive. And so one of our big learning points for this is we really need to develop methods for being able to address missingness in these data sets. And that's now another project that we've just embarked on, is whether or not the extent to which we can use large language models to address missing as a method to address high levels of missingness in routinely collected data. Because the thing that our learning point from this is that there's a huge amount of promise, actually more than we expected, for this approach of using multi-agency data for predictive purposes. Although 0.75 is really promising, it's in no way anywhere near accurate enough to enable us to use this for clinical purposes. However, there's so many things that we can do to help to build on this. So one is access to the broader range of variables by including the variables in the Delphi study that we weren't able to include, by doing the analysis, the work to be able to operationalize those variables. And the second point is we really need to develop a program that helps us address the quality of the data that we're using for the predictive models. And so at the moment, so now we've got 2 programs. So one is looking to operationalize those missing variables from the linked data, and the second is to really think about if we can address data quality in the context of missing not at random and high proportions of missing data. So some of the variables, for example, are 60–70% missing, but there were variables that we're really interested in. So is it possible to do that? So that's our current piece of work that we're working on to improve these prototypes. Kind of stole my own thunder there. And then the second thing is that this work we've been doing in SAIL as you'll all know, one of the key issues is around generalizability. So the next step for this work is to think about actually, can we translate these models that we're building and this work that we're building to the Cambridge data set, so which is called CADRA, where we're building this equivalent linked data set. And actually also I should add, as part of the mental health mission, this linked data network is being adopted now by 5 sites, and we're going to have the ability to do federated predictive analytics across those 5 sites, and that will be the next stage after that, is saying actually, can we build these models with these really large data sets across multiple sites. So I'll stop there. Thank you very much. My contact details top left if anyone wants to get in touch.